Hello, my name is Arif Khan. I'm a pediatric ophthalmologist at Cleveland Clinic Abu Dhabi, and it's my pleasure to welcome you to ESO 2024, and in particular to welcome one of our guest speakers, Dr. Paul Phillips, professor and consultant in the Department of Ophthalmology at the University of Arkansas Medical Sciences in Little Rock, Arkansas. And also director of the Jones Eye Institute, where he's chairman. And Paul, it's great to have you here.
I'm honored to be here. It's been a great meeting.
Paul is really very exquisitely trained in both pediatric ophthalmology. You did your pediatric ophthalmology fellowship in Wilmer.
Correct.
Johns Hopkins. And after that, you did a neuro-ophthalmology fellowship. So what made you decide to do both? I mean, I myself am a pediatric ophthalmologist. I can understand the reasons for pediatric ophthalmology. What made you go on for a second fellowship?
It was totally by interest to combine them. I always liked neurology. I like neuro-ophthalmology. And, but I also wanted to do surgery. So I felt that pediatric ophthalmology and strabismus and the way the muscles and motility, ocular motility functioned, combined very well with other aspects of neuro-ophthalmology. So totally combine those two interests.
And how has doing both, how has that informed your practice? How has that influenced the way you see patients, think about disease?
Oh, it's been tremendous help. Neuro-ophthalmology fulfills a scotoma. You have ophthalmologists who don't like to look at neurologic disease, and then you have neurologists who can't examine the eye, and you have neurosurgeons who are somewhere in the middle. So as neuro-ophthalmologists, you have the advantage of combining the accurate eye exam with knowledge of the neurologic system. And when you add pediatric ophthalmology on top of that, you now know how to examine kids. So you're fulfilling a combination of things that very few people other have.
It's a unique niche, yeah.
When I go to the neuro-ophthalmology meetings, they're all intimidated by kids. They're used to adults who can give accurate visual acuity. So you get comfortable with all sides of the spectrum.
I can see that. You know, you mentioned the word intimidating. One of the things that intimidates many physicians, ophthalmologists and non-ophthalmologists, is nystagmus. And actually, even ophthalmologists are reluctant to even talk about nystagmus or give lectures. And very often there's a knee-jerk reaction to order neuroimaging for patients with nystagmus. So, you know, I know you have an interest in nystagmus. You have a keynote talk about an approach to nystagmus. What's your advice to you know, ophthalmologists, non-subspecialists, you know,
sure.
people who are not pediatric, people who are not neuro-ophthalmologists, when they encounter a patient with nystagmus, should they order MRIs with a low threshold? Does it matter if it's a child or an adult?
So
What do we tell general ophthalmologists?
So to take the questions in reverse, so neuroimaging is actually not indicated in the vast majority. And the reason why it's important for general ophthalmologists to know about this is because they're really the only ones. They're the ones most suited to figure it out. If you send the child to a neurologist, some ophthalmologists get intimidated by nystagmus. They say, I'll just have the neurologist deal with it. But the neurologist will order the scan, which will most times be normal, and they will not know how to detect the associated ocular conditions that are causing the nystagmus. So it has always been my goal to, I say, bring nystagmus to the masses. It's actually a lot of fun when you understand it.
Yes, that's definitely true. You know, what a gap this is filling. I agree with you completely. You know, it's very interesting. If a patient with nystagmus goes to neurology, it's inevitable that they're going to get neuroimaging. But
absolutely,
especially, you know, there tends to be a fear of neuro-ophthalmology, and there tends to be a fear of pediatrics also. And you have absolutely stated it very succinctly. It's our duty to examine and understand these patients, because if we don't do it as ophthalmologists, no one else.
Absolutely. You can't, as you stated, you can't defer this to the neurologist. And when you understand it, it's actually gratifying. The general ophthalmologist will certainly pick up media opacities and cataracts much better, way better than the neurologists. They're going to pick up foveal hypoplasia. They're going to pick up optic nerve hypoplasia. These are all things that general ophthalmologists can detect. And once they understand how that's related to the nystagmus, they'll be less intimidated and able to work up those patients.
So if you have a child who comes in with nystagmus, it's often hard to know when the onset was. It might have been from infancy. It might have been a little bit after that. If the child is otherwise completely healthy and there's no abnormality that's visible on the ophthalmic exam by ophthalmoscopy, what's the likelihood that that could be from neurological disease?
Highly unlikely. So if it's typical pattern, and I'll discuss the pattern in my lecture, but they all have a similar pattern. They're horizontal, at least clinically horizontal, pendula, left beating, left gaze, right beating, right gaze. They stay horizontal and up and down gaze. And they're conjugate, meaning both eyes are doing the same thing. If it fulfills all those characteristics, then, and the rest of the eye exam is normal, the optic nerve in the retina is normal, there's not going to be a brain tumor. So neuroimaging is not the way to go.
Yeah, yeah. I would say in the majority of the children, if they're otherwise healthy and there's no optic nerve pallor,
yeah,
there's no need.
Yeah, I agree completely. And the signs that make you worried, such as a vertical component or asymmetry, where one eye has nystagmus and the other eye is not conjugate, is not matching, that's pretty rare. Those are the ones where I get a little more concerned. But in a given day, I see kids day in and day out with the more common types of nystagmus, like I just described. Again, conjugate, horizontal, and most of them do not need neuroimaging and will not have anything dangerous.
Once again, this is a very important topic for us as ophthalmologists because it's really our turf to handle this, and we're so happy that you're able to come and speak to us. We're looking forward to your talk. Just, to conclude, I know this is the first time to the UAE for you. Thanks again for coming. How's your experience been so far? What have you seen? Any surprises?
It's just been amazing. I'm surprised at the emphasis on diversity, the wide range of cultures here, how quickly it's built up. I hear 30, 40 years ago, almost none of this was here, and now it's just, it's phenomenal what's been built up in a short amount of time. And we've gotten to do, I'm here with my family, my mother and my wife.
Fantastic.
And they're at the Louvre now. I'm gonna go tomorrow. We were in Dubai. We saw the Sheikh's Palace, the Gold District, the Spice District. My wife's a cook, so she got to buy some of those. But it's just been a phenomenal visit, and I'm here for 2 or 3 more days. So looking forward to more.
We're so happy you came, and hopefully we'll see you again here.
I'm happy to come back.
Okay. Thanks again, and see you at ESO 2024.